Good afternoon, everyone. Welcome to this PHA Live webinar, Unraveling the Link Between Sleep Apnea and Pulmonary Hypertension. Thank you for joining us today. We will begin shortly. We are allowing time for everyone to come on in to the webinar. We will begin in one moment. All right, I see people starting to come in. Thank you again for joining us. Welcome to the PHA Live webinar, Unraveling the Link Between Sleep Apnea and Pulmonary Hypertension. Before we get started, I would like to take a moment to thank our sponsors for helping to support the PHA Connects program. Although sponsors do support our programming, they do not participate in the development of and do not endorse content of the programming. So thank you so much to our sponsors. We also would like to thank you who are members. If you're not a member and are interested, you can reach out to memberships at phassociation.org. Joining the Pulmonary Hypertension Association helps to raise PH awareness, empowers and support patients and their families, builds meaningful connections, and helps us with our mission to find a cure. So again, thank you if you are a member, and if you're interested in becoming a member, please reach out and we'll get that information to you. A couple of programming notes that we have for this webinar today. We will have Q&A immediately following our presentation from our lovely speakers. You can use the Q&A button in your toolbar to submit those questions. And then also, to continue the programming like this one and to know what you're interested in, we will have a survey that will pop up in a new window once the webinar concludes. Please take a few moments to complete that survey. Again, that helps us to know which programming you're interested in and what you would like to see in the future. And so a little bit about our panel. We are so happy to have Dr. Farmer and Tanya Zeiger. Dr. Farmer is the Director of Pulmonary Hypertension Services at Bayside Health, and Tanya is a respiratory therapist at the Mayo Clinic. So we are excited to have them here today for unraveling the link between sleep apnea and pulmonary hypertension. To get started, we will start with Dr. Farmer, who will give us a baseline understanding of sleep apnea and pulmonary hypertension. Dr. Farmer.
Thank you for that lovely introduction, Angela. And I just want to make sure that everyone can hear me okay.
Yes.
Thumbs up. Okay. All right. Well, good afternoon. My job is to kind of give the introduction to this presentation with my colleague, Tanya from the Mayo Clinic. So let's talk a little bit about what exactly is sleep apnea. And I'm going to focus on obstructive sleep apnea in particular. So as a general definition, sleep apnea is a sleep disorder characterized by pauses in breathing or periods of shallow breathing during sleep. Each of those pauses can last from a few seconds to several minutes and can occur many times during any period of sleep. And it doesn't really matter if the sleep is occurring during the daytime as a nap or during the night, or, if you do shift work, obviously you sleep off of cycle. These events are usually associated with snoring. And as breathing resumes, there may also be choking or snorting that occurs with these periods of shallow breathing. Next slide. So obstructive sleep apnea is a particular type of sleep apnea, and it's characterized by what we call obstructive apneas and hypopneas and respiratory effort related arousals. due to repetitive collapse of the upper airway during sleep. So any type of obstructive event typically involves the back of the throat, in other words. So, and we'll talk a little about these specific events, but an apnea is obviously a more significant event because that involves stopping to breathe for at least 10 seconds, where a hypopnea more so looks at shallow breathing with an associated desaturation in the oxygen level. And the respiratory effort related arousal is a less severe form of an obstructive type of event that can occur during sleep. Daytime symptoms attributed to disrupted sleep and sleep apnea can include sleepiness, fatigue, or poor concentration. Again, the signs of disturbed sleep, and most often these are noticed by the significant other or the bed partner, or sometimes even someone sleeping in the next room, include snoring, restlessness, or resuscitative snorts or gasps following these events. Next slide. So this is an example from an obstructive apnea that the physician interpreting a 16-channel in-lab polysomnogram would see on or recorded during the sleep study. So you can see there where the red arrow shows that there's been a cessation of airflow. If you look to the left, you can see the channels are all labeled there, and the red arrow points to the flow channel, where there is a significant time period where the line is flat. So that signifies no flow. At the other end, we know this is an obstructive event because when we look at the thoracic channel, and also the abdominal channel. So remember, there are little motion sensors on the chest and on the abdomen that are recording the rise and fall of those two structures or not, right? But you can see there the green arrow shows that there's respiratory associated movement. However, there's no flow of air. So this defines an obstructive apnea. Next slide. So what are the consequences of untreated OSA? It's fairly easily ignored, some of these symptoms. Many times in the sleep clinic, the patient presents because the significant other or bed partner has encouraged them to do so, because they are the ones that hear this, that are woken up by the snoring, that sometimes will realize that the patient is stopping to breathe or having these periods where they're not breathing. So the patient may report excessive daytime sleepiness, impaired daytime function, meaning poor concentration, falling asleep at the desk, falling asleep at any time during the day. Metabolic dysfunction. So there are many studies showing changes in blood glucose. Also, increase in blood pressure is something that is a well-documented effect of lack of good quality sleep. So that instead of sleep being restful and the blood pressure falling and the heart rate falling, when these obstructive apneas and hypopneas are occurring, the blood pressure doesn't fall like it's supposed to during sleep, but will actually rise. And that happens, we can see that happening in the sleep lab. And we can also, studies have been done that this then carries over into the daytime. And then also there's this phenomenon of decreased oxygen saturation that also occurs during sleep associated with these apnea and hypopnea events. Next slide. So what are some of the risk factors to think about if you're concerned that you or a loved one may have sleep apnea? So some of the well-documented risk factors are, first of all, male gender, advancing age, obesity, And obesity is associated with an increase in neck circumference and also the body mass index, and that body mass index being a ratio of weight to height. And then any type of craniofacial or upper airway soft tissue abnormality, such as enlarged tonsils, structural changes with the jaw and other bones that support the mouth, or that anything that can cause a narrow airway. Unfortunately, sometimes it's our genetics and kind of the structure of our mouth and the back of the throat that we were kind of given at birth. That's why tall, thin people, even though it sounds counterintuitive, because we really associate obstructive sleep apnea and the hypopneas with being overweight or being obese. Sometimes it's a tall, thin person that is just born with a crowded airway or a crowded back of the throat that actually can develop sleep apnea. Next slide. Also, some medical conditions can be associated with sleep apnea. In addition to overweight, any type of connective tissue disease that can affect the back of the throat and the large tonsils, chronic lung disease, strokes, heart failure, end-stage kidney disease or renal disease, and pregnancy may all predispose someone to developing sleep apnea. Family history is thought to be significant. So as part of a good sleep history, one should be asking about snoring or history of obstructive apnea, obstructive sleep apnea, or use of a CPAP machine, in mom, dad, siblings, aunts, uncles within the patient's family. Menopause can cause changes, in the hormone levels, right? Predisposed to weight gain. So we always want to ask, obviously age and menopausal status. Nasal congestion, if one can't breathe through the nose or has had a history of a broken nose or sinus congestion, polyps, or those things will make nasal breathing difficult and may cause some mouth breathing during sleep and therefore be a setup for developing sleep apnea. And also smoking is another risk factor associated with sleep apnea. So the American Academy of Sleep Medicine has standards for what is considered to be a thorough and comprehensive sleep medicine evaluation. This includes a very detailed history with a questionnaire that's completed either with the patient during that initial evaluation, or sometimes can be mailed to the patient prior to the sleep medicine consultation, where we ask about knowledge of snoring, stopping to breathe in the sleep, things that may awaken the patient up at night, such as chronic postnasal drip, coughing, reflux disease, whether the patient reports excessive sleepiness during the day, difficulty with staying awake while driving, difficulty with staying awake, for instance, after eating, a lunch or dinner. We talk about leg movements during sleep. We also ask questions related to perhaps narcolepsy, whether significant emotion has caused anyone to, suddenly drop to the ground. So these are some of the comprehensive questions. We ask about family history, smoking, whether there's been any prior diagnostic testing. So that includes either a home sleep study these days or an in-lab polysomnogram. So it used to be that we were doing more of those 16-channel in-lab studies. However, we realized that because the technology has improved, the home sleep apnea tests give us fairly reliable information in situations where the patient is sort of a setup for obstructive sleep apnea. So if we're able to do a home sleep study, most patients find this more convenient because they obviously don't have to come into a sleep center or a sleep laboratory and sleep overnight. They're more comfortable in their own environment. And we're able to get good quality data with the current technology. So sometimes a home sleep study is significant. The data is good quality, and we can make the diagnosis of obstructive sleep apnea that way. Or if the home sleep study is equivocal, but the patient is still then symptomatic, so we have a clinical suspicion that the home sleep study underestimated the severity of sleep disordered breathing, we then can bring the patient into the laboratory for a polysomnogram. And then adequate follow-up is recommended. So it's just not enough to make the diagnosis and put the patient on a CPAP machine. Insurance requirements now want the patient followed by ideally a sleep medicine physician, where we download compliance data from the machine, and are able to follow the patient through the process, get them acclimated to the machine, make sure the machine is set appropriately, make sure the interface or mask is comfortable and that there's not a high mask leak. So there's quite a bit of information that needs to be documented to make sure that the patient is, starts off on the right foot, because we know that problems up front kind of, sometimes don't bode well down the road. So we do want to work with the patient and improve those barriers up front. So that's why adequate follow-up is important. So just a few words regarding treatment. OSA typically is a chronic disease that requires long-term management. Even in situations where significant weight loss occurs, occasionally that patient can remove enough weight from around the neck that the significant number of obstructive events may diminish, and the patient doesn't need, a CPAP machine anymore. However, remember, the goals of therapy include reducing or eliminating sleep disordered breathing events. That is, we want to take care of those and minimize or eliminate, first of all, the number of apneas, then the number of hypopneas, and then those shallow breaths that result in arousals. And those are those respiratory related events that I talked about earlier. And lastly, snoring. And then another important goal is to reduce the oxygen desaturation that occurs with these events, because it's the oxygen desaturation that can actually contribute to the development of mild pulmonary hypertension. Next slide. So patient education, and this is another important component of comprehensive sleep care. So we want to make sure and counsel every time that we see the patient, either in a telemedicine visit or in the office, that there is an increased risk of motor vehicle accidents associated with untreated obstructive sleep apnea. So we want to make sure the patient is aware not to drive while drowsy. If there's a break, for instance, in their CPAP use, or if they're going through the process of being diagnosed with potential obstructive sleep apnea. So we want to keep the patient safe, and we want to keep others also around them that could be, on the road safe. We want the patient to understand the potential consequences of driving or operating other dangerous equipment while sleepy. So this includes school bus drivers, right? This includes tractor trailer truck drivers. This includes forklift operators, right? Any kind of heavy equipment, construction equipment. We want to make sure that the patients that are operating those types of vehicles are safe and, have good concentration ability. Patients should be counseled to avoid activities that require vigilance and alertness if they're sleepy. Again, we emphasize the importance of weight loss and exercise. and also abstaining from alcohol and medications that can exacerbate sleep disordered breathing. So we know that alcohol can obviously make sleep disordered breathing worse. That's been well documented in clinical studies. And there are medications such as benzodiazepines or pain medications that can actually make sleep disordered breathing worse. So with those introductory points, I'll now turn the presentation over to my colleague, Tanya, who will talk about after diagnosis of obstructive sleep apnea.
Hi, I'm Tanya Zeiger. I'm a pulmonary hypertension coordinator here at Mayo Clinic in Jacksonville, Florida. I'm also, by background, a respiratory therapist and help you with questions today. First and foremost, I want to echo Dr. Farmer in saying that once sleep apnea is diagnosed, is not an end of the road deal. You've got to keep coming back. You've got to actually be rechecked. It's really, really important with the pulmonary hypertension that you do not continue with low oxygen levels even after you start treatment. So when you've actually followed up with your pulmonary hypertension specialist or your sleep specialist, they can actually download the cards for your equipment to make sure that you're actually using it appropriately and using it in a timely fashion. The physician that you see will be ensuring that you have compliance. That, again, as Dr. Farmer said, is really important for insurance so that they are able to cover it. Overnight oximetry while on treatment will actually ensure that you don't need to have additional oxygen entrained into your BiPAP or CPAP devices that's treating your sleep apnea. So this is a great example of the overnight oximetry that was done on a patient after they were on 3 liters of oxygen. This being said, I want to bring to your attention up here is the time in minutes that the patient spent under 89% of oxygen or oxygenation by pulse ox. So if you look at that, you can see that their normal quote unquote oxygen level is 82. That tells us that what they're doing is not working. In a case like this, because of the underlying low oxygen levels, it will actually worsen sleep apnea. We've seen it time and time again. It seems like such a simple fix, but it really isn't. But you know, that's one of those things you've got to keep going back. You've got to keep double checking to make sure, especially if you have a weight gain or a weight loss, you want to make sure and go back and make sure that your interface device, whether it's a mask or nasal pillows or what have you, is all still functioning properly and you're not leaking. So how does sleep apnea play into pulmonary hypertension? It does play a role. Usually if your pulmonary hypertension is caused by sleep apnea, it's technically, according to the latest guidelines, not caused by sleep apnea. It's caused by low oxygen levels. So that being said, a lot of times what we do is we go ahead and treat the patient for their sleep apnea. And once they've been on therapy for about 3 to 6 months, then we will go and start going through the additional testing for pulmonary hypertension. With that, the reason that we do that is because if your pulmonary hypertension is still there and your sleep apnea is being treated appropriately, then you've definitely got an underlying issue. And you probably would need medications for that. So any forms of sleep apnea would actually lead to low oxygen levels. That can be positional, it can be central. A lot of our patients have a low ejection fraction, and a lot of times those lead to a different form of sleep apnea that's a central sleep apnea. It's basically the brain. If that happens, the patient actually needs what we call a BiPAP. It's kind of like a CPAP, but it has 2 levels. And those, oops, sorry, am I still local? Yeah, sorry, I hit my button and I wasn't sure that I was still talking. It has two levels, and the levels are inspiratory and expiratory, and that is essentially the way that your body would breathe while you sleep. Low oxygen levels definitely worsen pulmonary hypertension. Even if you weren't to need a device like CPAP or BiPAP, you would still, in some cases, need oxygen. And if you need oxygen, you need to use it religiously. It will not help you to use your devices or your oxygen periodically. So that's the reason that when we follow up, we make sure that your compliance level is appropriate as well. So what does hypoxia do? Hypoxia is a low oxygen level. So I want to point out, this is the blood vessel with normal oxygen levels. You see it's nice and wide open. These are relatively thin intima or inner linings. If you are short of breath or your oxygen level drops acutely, in other words, it drops and it comes right back up. I hear all the time from people, oh, yeah, my oxygen level drops when I exercise, but as soon as I sit down, it comes up within 3 or 4 minutes. That's what we call acute hypoxia. When you have that, you see the difference in how open your blood vessel is. So its response is to actually constrict. That's just what it does. So as your oxygen level drops, your blood vessel constricts. As it goes back up, it reopens up. So if you do that chronically, what happens is not only does it restrict, but then you start building additional layers in those blood vessels. So the blood vessels thicken, it's like a stiff hose, and it can't expand anymore. So it actually starts tightening down. And in some cases, it tightens down to a point that there's not a lot we can do to loosen it up unless the patient's using their oxygen. So treatments, there's a lot going on here. So let's just start from scratch. The first treatment that everybody knows about is continuous positive airway pressure. That is one of these type of machines, and that machine actually pushes air in when you're inhaling. When you exhale, it just relaxes, it doesn't do anything. Bilevel, as I said before, is when you breathe in, it's got a pressure. When you breathe out, it keeps and maintains a pressure. So you're never actually going back to real baseline. You're essentially going back to a higher pressure. Automatic positive airway pressure is where the machine is going to decide what pressures you use. I personally don't have a lot of love for these machines, mainly because I myself am a patient and I used one and it didn't work for me. That doesn't mean that it doesn't work for some people. And some people swear by it. It works well. It controls their oxygen issues and everything is good. Positional therapy, some people only have their apneas when they're laying on their back. If that's the case, back 800 years ago when I started this, there was no fancy dancy little device. We actually had patients sew tennis balls into the back of their t-shirts and sleep in that t-shirt so that if they tried to roll over, they would actually land on these tennis balls and it would be uncomfortable and they would turn back onto their side. Now they have these wonderful little devices that does the same thing, except this is a little bit gentler device that you still will be uncomfortable and you still will turn back. It's just a matter of not actually digging tennis balls into your body. Then we get into a little more invasive options. Nasal surgery sometimes helps. The oral dental appliances down here are actually appliances that are created by or made by dentists that are in association with sleep departments or sleep labs. What those do is work at trying to keep the back of your airway open while you're sleeping, and that will assist so that you don't have the blockage. The other options are, this is a device that has a stimulator. So it goes up and it actually is implanted just like a pacemaker would be. And it threads up into your neck area and it will actually stimulate that nerve. If it feels like it's starting to slack, it'll stimulate the nerve, it tightens up and then opens up the airway. The other two are even more invasive. This is a technique where they actually strengthen the back of the top of your mouth by using these little implants. And those are essentially little rods. And what that does is it keeps the back of the airway from collapsing. The last intervention is where they actually shift your entire jaw. And what they do is significant. It does work for patients, but it is a significant commitment as they go in and they essentially break the bones, move your jaw forward, and then reattach them. So helpful hints for sleep machines. If you need to use oxygen with your CPAP, BiPAP, APAP, whatever PAP you're using, it has to be continuous flow. If you think about these machines, their entire job is to keep a pressure, whether that's inspiratory, expiratory, both, it keeps pressure. If it's keeping a pressure, if you have a pulse machine and it's periodically opening to the air, then suddenly you no longer have a closed system. Neither machine knows what it's doing, and both machines will alarm and you won't get any sleep. A lot of times in the evolution of oxygen companies, we've lost that thought process, and even in doctors' offices. If you were to call a doctor and they weren't aware that you were also a sleep patient, sure, you can have a portable oxygen concentrator for your trip. I think that would be great for you when you exercise. But what you can't do is sleep with it with your oxygen or with your assistive devices. So I always tell my patients, when you go forth and say, I'm going on a trip, I need to get a portable oxygen concentrator, volunteer to them. I also have a CPAP. What can I use something? And if I can, what is it? If you're using portable oxygen, got to have continuous flow, without a doubt. Now, there are some portable oxygen concentrators that do have continuous flow. And this is a list of some that I know of, and we will provide this after the fact. I believe Angela's going to put it on the main screens. But the nice part about this list is, unfortunately, the highest that a portable concentrator will go is up to 3 liters continuous flow. There are no machines on the market that do anything above 3 liters continuous flow. There are lots of machines that go a lot higher in pulse flow only. But if you are using it with an assistive device, you've got to have that opportunity to turn it to continuous up to the liter flow you need. That being the case, if you were somebody who needs 6 liters entrained into your BiPAP while you're sleeping, there really isn't a good option for you, unfortunately, for portability. What I tell my patients at that point is to really coordinate with your oxygen company. If you call your oxygen company and you say, hey, I'm traveling, I can get from point A to point B, but I can't get what I need once I'm there, a lot of times they will be very, very helpful. And usually, even if it's a super small company, they usually have a sister company that's national, and they will have something delivered to you. Of course, the worst option is to have to drag your big home concentrator with you, and that is not practical and not even a consideration that my patients are going to do. If you look here, you will see that, yes, all of these only go to 3 liters, but a lot of these actually have pulse settings that are much, much higher. As a matter of fact, this one will say that it goes up to 10. The 10 that it's talking about is not liters per minute. The 10 that it's talking about is actually pulse flow. So it's how much air or oxygen you get when you sniff with each breath. So that's really important because each one of these, their pulse flow can be different. There is no legislation that makes it across the board. So every pulse you get is going to be 16 cc's or what have you. It's up to the individual manufacturer to decide how much milliliters you're going to get per puff. And a lot of times, if you're not aware of that, you're thinking, oh, this one's great, it goes up to 10. Well, unfortunately, that 10 that it says it has the machine can still only produce 3 liters. If you were to outbreathe the machine, in other words, if you had it set to 10 and you were getting 192 mLs per puff, if you were to breathe more than 10 times a minute, it's going to shut down. It's going to say, nope, I can't do this, and it shuts down. And so those are the calls that I get that patients will say, oh, my machine's broken. It's really not. It's just not giving you what you need. So the bottom line there is always carry a pulse ox with you. Make sure that your oxygen level is staying above 90% at all times, and I'm a happy coordinator. So take home message. Big take home message here is always, always, always keep your oxygen level, if you're able to, above 90% at all times. That being said, I know that there are some congenital heart patients out there that their normal oxygen level maybe can get to 75, that they know what their limits are. A normal person who has pulmonary hypertension needs to keep their oxygen levels greater than 90. That's no matter what. That doesn't matter if it's walking, sitting, running to the mailbox. It needs to stay above 90. If you are having problems, make sure that you take some time. Talk to your office, talk to your sleep specialist, say, hey, what you gave me is just not working out for me. I don't know what I can do about this, but I don't like what I've got. Can we work out something else? And stay in contact. Try different things. Don't say, oh, I tried a treatment once and it didn't work for me. There are a lot of treatments out there. Along that vein, I did not do a ton of informational slides. I'm sure that you all have Googled them, but there are a lot of different options out there. Some of them range from just having little pillows that attach. Some of them still have the headgears. Some of patients still need a full face mask. And some patients don't even use the face mask that goes over just the nose and the mouth. They use a full face mask that goes over the eyes as well. As far as actual devices, we are blessed with a plethora of newness. We have a lot of travel CPAPs now. But again, that's a travel CPAP. I just got back from a trip. So if you're traveling, as I was with my BiPAP, I actually break mine down so that my actual BiPAP and its electronic piece is actually in a bag separate. So that if I didn't have TSA pre-check before I got that, I would just take that one little bag out and drop it in the TSA line. They now are very familiar with TSA. They really can recognize a lot of times those devices. Where you sometimes get a little more issue is if you've got your CPAP or BiPAP and your oxygen. So with the airlines, each of the airlines has their own guidelines as far as oxygen. You're best to look at your actual airline, see what they require. It's usually under accessibility, under the airline's webpage. Just look there, say, oh, they just need a letter from my doctor saying I can hear alarms and I can address them. And what do I need when I'm flying? That's perfect. Some airlines are a little more persnickety. Some of the worst that I've gotten have been several pages that you fill out to delineate that, yes, the patient can safely fly, they can hear, they can see, what exactly is the illness, can it be spread? It's very interesting how some of the airlines take the ball and run with it. All of that said, I'm going to go ahead and take over with some questions, and I will stop sharing now. If you do have questions, use the Q&A button. I know that there's been a couple that have come through. I will go ahead and see if I can tackle at least the first one as far as the docs with OSA. I will tell you that without a doubt, obstructive sleep apnea does contribute directly to your pulmonary hypertension. It will worsen your pulmonary hypertension if you are not treated. If you're treated appropriately, it has nothing no play in it at all. But you've got to get that treatment exactly right, and you got to stay on it. That's key. You have to be consistent. Your body doesn't really respond well to, well, I used it one day last week, or I slept with it twice, but I take a lot of naps and I don't want to use it during a nap. Your body still sees a desaturation and oxygen level drop as an oxygen level drop. It's still going to constrict, and our goal is to open up and dilate those blood vessels, not to constrict them.
So I'm just going to hop in here for a moment. What Tanya said is absolutely correct. I just want to add that the current teaching, because the question focused on the severities of, so the sleep apnea, if it results in pulmonary hypertension and is the sole culprit, typically the teaching is that OSA, untreated OSA or untreated sleep apnea will result in mild pulmonary hypertension. So that's the key. If your pulmonary hypertension specialist tells you that your pulmonary hypertension falls in the moderate to severe category, you may also have sleep apnea, but then it's time to look for other things contributing to those elevated pulmonary pressures up in the pulmonary circulation. So I guess I'll take the next question. So how many types of sleep apnea are there, and how can I find out which type I have? So this should be a conversation with your sleep medicine provider, or the person who actually ordered, the provider that ordered the sleep study and has the actual sleep study report and the raw data from the sleep study accessible to them. Because the type of events that are identified on the sleep study should all be listed there as to whether they were obstructive apneas, obstructive hypopneas, central apneas, central hypopneas, or mixed. So that's a conversation with your sleep medicine provider, primary care, or I said whichever physician ordered the sleep study and is discussing the results with you. I guess the next question kind of leads into that, right?
Yeah, so
hypopneas, go ahead, Tanya.
Oh no, go ahead.
Yeah.
I was on the next one.
Oh, okay. So hypopnea is always considered as obstructive sleep apnea. So the answer to that question is no. There are also central sleep apneas. And that's a matter of how these events occur on those channels that I showed you that are part of the sleep study. So the types of hypopneas in general are obstructive and central.
So the next question had, well, it wasn't really a question, it was a statement. Unfortunately, yes, oxygen companies do routinely not necessarily pay attention as they should, and they will send you a portable concentrator that does pulse only and think they're doing the best thing for you because they're giving you the lightest and easiest thing to use, right? Unfortunately, it doesn't work that way if it doesn't work for you. So yes, you have to be your own advocate. You have to look at that and go, no, you guys need to try again. Along that line, if you have a portable concentrator that does do continuous flow, it's perfectly fine to turn it to pulse flow during the day when you're out and about, as long as that oxygen level stays up. For us, that's the best of all worlds. If you can keep your oxygen level up during using pulse flow during the day, that's fantastic because you know that extends the battery life of the oxygen concentrator. If you have the ability to use it at night and entrain it attach it to your CPAP, BiPAP, APAP, again, perfect. So a lot of times if somebody's coming to me and saying, what's the best option to purchase? I typically lean towards a option where you can get up to 3 liters continuous flow, as well as the pulse flow. So the reason really being is that I would hate for you to go out and buy a concentrator that would either only do pulse flow and you have sleep issues, or B, you would get something that will only give you 2 liters, and you may actually get a little worse as time goes on, and you may need more, and you would end up having to buy another piece of equipment. I have many patients who have multiple pieces of equipment for that reason. So I hope that that answers the question. And I will tell you that most oxygen companies will not give you a portable oxygen concentrator for home use. I've had to battle that quite a bit. They typically balk at it a lot, mainly because of the battery life situation, and the sieves that are inside the portable concentrator have to be replaced after a certain amount of usage. So it's not quite as durable as the home concentrator, for what that's worth.
So I think we're on to the question in regards to, so this is a great question, actually. What's the average time from onset of sleep apnea to diagnosis and treatment? So the answers here are interesting and kind of all over the map, right? The American Academy of Sleep Medicine has actually looked at this and said it can take up to 10 years. If someone just is, kind of not complaining or not willing to deal or doesn't mention it to their physician as a concern, right? And is kind of hoping it's going to go away, or maybe it's not so bad, right? The answer to the question from the American Academy is 10 years. Now, once your primary care or pulmonologist, cardiologist, whomever is, you convince them of your symptoms, right? And they do maybe a little sleep history as part of your office visit. We had, and now I think we're out of COVID, right? Because boy, did we neglect sleep apnea during COVID, right? No sleep labs were open. No one was coming to pick up home tests. So things got really delayed there. And then we had the whole chip shortage, right? And with the construction or the manufacturing of new sleep apnea machines, right? So in a much better place now, we've moved forward. So I would say once you bring your concerns to the quote unquote average clinician, I think you're probably looking at maybe 7 to 9 months. Maybe some systems are a little faster than others, but by the time the evaluation occurs, the sleep study is ordered, it's got to get insurance approval, you have to get studied, then the results go back to the ordering provider, then there's a conversation about, how to treat. I think that's kind of fair. Maybe that's a little overestimate, but, I think the concerns need to be brought to the attention, of the provider first.
And that's not all encompassing. Just because you mentioned it 3 years ago when you were tested doesn't mean that you haven't developed it since. So if those symptoms persist, you need to again say, just an FYI, I'm still snoring, I'm still tired during the day. My husband says I wake up gasping. Those are real concerns. Those are things that you definitely need to bring back to your doctor's attention. We have one patient we've been seeing since 2005, and just recently she was diagnosed after we tested her, I think 4 or 5 times throughout those years. She now has sleep apnea. That's just unfortunate, but it happens. And just because you have a disease doesn't mean you can't have another disease. So don't be lulled into the fact that, oh, I've got pulmonary hypertension, I'm supposed to be tired during the day. That's not really how that works. When it comes down to your oxygen levels, they need to be assessed by your sleep doctor. So what happens there is that you will have a test after you're on appropriate treatment. When they do the actual sleep study here at our institution, they will actually entrain oxygen if they can't get enough pressure. That being said, that's the reason that we talk about going back to make sure that everything is good, because they will retest you at another point in time. If they haven't needed oxygen, they'll test you on just your actual assisted unit. If you need oxygen there, they will titrate from there. It does not always mean that it's going to be the same amount as you would use with exercise, and it's not the same amount that you would use at rest. The reason it won't be the same as at rest is because you have a respiratory issue. When you lay down and your respiratory system is depressed, your oxygen levels go down a little bit, even further than when you're sitting up and sitting in your chair. So all of that said, it's something that really should be delineated out by actual testing and not just be a guessing game. Along that line, I am a firm believer. The doctor that I work with here is not a sleep specialist. We do not do sleep treatments. We actually have a separate division that we talk to and that we send our patients to that does just sleep. I really believe that while it's great to have a primary care provider who is willing to jump in, the chance that they're going to know all of the up and coming things and know what's really available and what is needed for insurance is pretty slim. I look at it as I wouldn't expect a primary care or a sleep doctor to know exactly what my patients need to have so that they can continue their IV drug. That's my specialty. So I look at them and say, they're up to snuff on this. I need to have their input. So essentially what our doctors typically do is part of the screening process is we do an overnight oximetry. If that overnight oximetry is abnormal, at that point, we will go ahead and order a sleep consultation, and the sleep doctor will take over the sleep issues from there. I think there's a question, Dr. Farmer, about
Is this the AFib one? Is that where we
yeah.
are? Yeah.
Yeah.
So how does AFib contribute to sleep? I think that's sleep apneas, right? And using the equipment. So kind of both, kind of vice versa, right? We know that we've seen that, as people unfortunately age a lot of times, and whether it's lung disease or cardiac disease, that is contributing a lot of times to the development of the AFib, because I like to think that the lungs and heart communicate with each other, right? In some way. We know that atrial fibrillation is a reason many times that a cardiologist will refer a patient for a sleep study. And so this has to do a lot of times with just ineffective blood flow, right? Ineffective what we call cardiac output because of the atrial fibrillation, which can affect oxygen saturation, right? So a lot of times that's what we're seeing on some of these sleep studies, is that because the heart isn't the effective pumper that it used to be, that sometimes that affects the oxygen flow and contributes to the oxygen desaturation. I mean, an AFib in itself should not prohibit compliance with the machine. So usually this is something that we look for when we look at general overall compliance. Who should I be working with to manage my pH? Cardiologist, pulmonologist, other. So typically it falls under the treatment of pulmonary hypertension falls under the purview of either cardiologist or pulmonologist. Some cardiologists will participate in doing the workup, such as the echo or the right heart cath, and then refer to the pulmonary hypertension specialist because, the medications, and with other therapies in the pipeline. So it really takes a lot of dedication, keeping up with the medications and how they're used. So I would say that to manage your pH, you should be working with a cardiologist and or a pulmonologist. And a lot of times it is a team of both, to manage your pH.
So my suggestion would be whichever one actually specializes in pulmonary hypertension. I unfortunately have had the terrible experience of having patients go and find out, their doctor says, oh yeah, I manage pulmonary hypertension, I got you. And come to find out when they're talking about taking over their meds and things like that, they have no idea what the manufacturer REMS program is, or, any number of things that I've gotten phone calls about. So there are sleep physicians that work with the pulmonologist and or cardiologist. Here at Mayo, we typically, as Dr. Farmer said, we are a pulmonary based unit. In Arizona and in Rochester, they are cardiology based units. So, it kind of spans the globe as far as that goes. So
I think we have time. This is Angela for at least one more question before we wrap it up for the day. I don't know if there's any lingering messages you want to leave our audience with, or if you see a question that will kind of end the call today.
So I just want to address how to attach the oxygen. Yes, you would essentially use the regular tubing that's coming off. Instead of the portable concentrator having the tubing that goes to your nose, you will have the plain double-sided tubing that's identical, and you would plug one into the actual concentrator and the other into the little, what I call nib, that is in between the hose and the actual machine. You would only know that it's okay to switch to pulse during the day by testing. Again, I am a huge advocate to make sure that my patients all have finger probes. I will tell them, give it a try. Put yourself on pulse flow so you can conserve, and check your oxygen levels. Get up and walk, check your oxygen levels. And as long as that stays above 90, I'm a happy camper. If, however, that doesn't hold you, then you need to go back to continuous flow. Most institutions can't test you on pulse flow because we don't have pulse flow machines, and they all have different guidelines. So they would vary way too much for somebody to have one of each machine. And if you're looking at purchasing, I would definitely make sure that you're purchasing from someplace that will give you a 30 or 60-day trial. I think that's really important, so that you don't get stuck with a $4,000 machine that you can't use. And to make sure you did understand, yes, if sleep apnea is properly treated, yes, your pulmonary hypertension that's mild can totally resolve. The key there is that it has to stay properly treated. So you still have to be seen, you still have to follow up. You follow up with your sleep specialist as well as your pulmonary hypertension team to make sure that everything stays on the straight and narrow.
Thank you, Tanya. And Dr. Farmer, any last remarks before we end the call today?
Nope. I, again, just want to advocate for you guys. Keep that oxygen level up. Keep moving as much as you can, and really pay attention, and you'll do the best.
And I just want to thank everyone for their interest, and the questions were fantastic. Wish we had more time to address them all.
Exactly.
Yeah. Thank you. Thank you both for presenting today and answering so many questions. I see the questions are still coming in. And then we received some beforehand. I think that a lot of information was covered. I would like to note that we will, be able to post these slides later onto our website. That information is most likely will be in the classroom, PHA classroom, and you'll be able to have a copy. I know someone requested one of the slides. I did put that image in the chat, but you will be able to have access to the slides. So again, thank you to our presenters. This was amazing. I feel like it could have gone on for another hour, but we do have to end there. However, the learning and engagement is not done. I would like to invite everyone, If you're able to join us tomorrow for the PH and sleep apnea virtual support group, it's just a way to build connection with other members of the PH community who may be dealing with sleep apnea as well. So we hope that you will join us for that. I have put the link in the chat, and you can also find the information on our website at phassociation.org. And also, we would like to take a moment to invite you to join us for PHA 2024. Our conference registration is now open. Attend the conference to join the PH Association and hundreds of the members of the PH community for just, again, a weekend of connection, education, and just engaging with each other. We hope to see you in Indianapolis. So again, thank you, everyone. Thanks for joining us. Thank you for your questions. Again, you'll find this later on our website, and we hope to see you on the next webinar. So see you soon.
Thank you.
Bye, everyone.
Thank you.
Thanks.